Greetings to you all from Sri Rama Hospital, Jagaipet, Andhra Pradesh, India. This is one of the series of online surgery classes conducted by Dr. Yogi Ram's Medical Education Center. And today's topic is on mass in the right hypochondriac region of the abdomen. A clinical discussion to arrive at clinical diagnosis, presented by Dr. Yogi Ram Bolisetty. So we're going to discuss about the right hypochondriac mass, but in general, now we will discuss with you about the masses in the right upper quadrant of the abdomen. So for example, a mass is there in this region. So where from it is arising? So these are the main intra-abdominal organs that are there in this region. So any one of these organs may be responsible for this causation of this mass. So let us just see by layers what structures are there in the right upper quadrant of the abdomen. The parietes, then the intra-abdominal contents, the liver, gallbladder, pylorus of the stomach, greater momentum, transverse colon, C-loop of the duodenum, head and neck of the pancreas, kidneys, right kidney, then the retroperitoneum, having the mesenchymal tissues as well as the various muscles or nerve structures and the diaphragm and the related spaces beneath the diaphragm. So they can be parietal and retroperitoneal masses and intraperitoneal masses. Parietal swelling, all the skin and soft tissue masses can arise from the parietes of the abdomen. Retroperitoneal swellings, all mesenchymal swellings and cysts can be there in the retroperitoneum, commonly due to lipoma, fibrosarcoma, cysts and lymph nodal masses. Then many of the other things are the intraperitoneal masses. Broadly, these are the structures that are there in the right hypochondriac region. So you must broadly remember about these organs: the liver, kidney, stomach, colon, gallbladder and bile ducts. I will now briefly review the clinical features of each of these organs. So first we'll start with the liver. So as you all know, enlargement of the liver is called as the hepatomegaly. Features of a liver swelling. Tell me, what are the features of liver swelling? The swelling is there in the right hypochondriac region. If it is arising from the liver, so what features will it possess?
Moving with respiration.
Very good.
It will be continuous with liver dullness.
Yes. Number two, it is continuous with liver dullness. That means it is dull on percussion and continuous with liver dullness. Next.
Unable to insinuate the fingers below the right costal margin.
Insinuate the fingers between the costal margin and the swelling. Very good. Next.
Upper border of the swelling won't be clear cut.
Yes, can't be palpable. Upper border of the swelling cannot be palpable. Next. What about side to side mobility and up and down mobility? Usually it is restricted. So the liver swelling may be diffuse enlargement of the liver or it may be localized. Moves with respiration. Upper border not palpable. Dull on percussion continuous with liver dullness. Restricted mobility. Bimanually not palpable and not bilateral. Renal angles are normal. No associated visible peristalsis. So these are the features of a liver swelling. Now you can see here there is a diffuse enlargement of the liver, and in this case there is a localized mass arising from the right lobe of the liver. So palpable liver. So whenever liver is palpable means it need not be always due to an enlarged liver. It can be due to displaced liver, or it may be true hepatomegaly. Can you tell me the causes for displaced liver? Liver is pushed down.
Massive pneumothorax.
Very good. So any chest condition is space occupation in the right side of the chest. It can be a massive pneumothorax or it can be even emphysema. Very good. Any other thing? Correction of pus under the dome of the diaphragm. That's called subphrenic abscess. Right superior anterior subphrenic space. If it is occupied with large amount of pus, then liver can be displaced downwards. Physiologically, liver is palpable in certain cases. What are they? If liver is palpable, is it pathological in every case or not?
No, sir.
Okay. So in which individuals liver is normally palpable?
Thin individuals.
Pardon? In? I can't get you. Thin individuals?
Yes, sir.
Okay. Actually, it is not thin individual. By the shape, the so-called habitus of a person, the human morphology is classified into 3 types. Do you know the body habitus classification? What you said is correct, but it's actually not called thin individual. So there are actually four grades. One is called the hypersthenic personality. Next is hyposthenic personality. Next is asthenic personality. And fourth one is sthenic personality. For a person who is having broad body, for example, broad shoulders, wide pelvis, wide costal margin, so the person appears very thick and his organs also are disposed horizontally. Heart is more wide than tall. Liver is not palpable. Liver is more wide. Stomach is tear horn shape. Transverse colon is in the epigastric region, high in the epigastric region. So that is called hypersthenic personality. The other end is asthenic personality. The personality will be thin and tall. The shoulders are not wide. The costal angle is acute. Liver is displaced downwards because it is tall. Stomach is J-shape. And the transverse colon hangs into the pelvis, not in the epigastric region. So the person appears very thin and tall. In between we have the hyposthenic and asthenic varieties, the grades. So liver is palpable in the asthenic and sthenic individuals. Similarly, up to 2 years of age or 3 years of age, liver is palpable normally. The other case is the displaced liver. It may be due to anything, space occupation in the right half of the chest. Then true hepatomegaly. So displaced liver can be due to emphysema, asthma, COPD, collection of fluid into the dome of the diaphragm in asthenic individuals with narrow costal angle. True hepatomegaly. It may be a generalized enlargement. This again can be classified into with jaundice. And with jaundice means it may be a regular enlargement or irregular enlargement. Then without jaundice, it can be without jaundice means again it can be regular or irregular enlargement. So that is why whenever you see a patient with hepatomegaly, you must look for these other two things also, whether there is jaundice or not, and next is whether the enlargement is smooth enlargement of the liver or irregular enlargement of the liver. It may be a localized enlargement of the liver, or it may be a massive enlargement. When the liver is enlarged below the level of the umbilicus, then we call that as a massive enlargement. Generalized enlargement along with jaundice. Tell me what conditions are there. So we have two types. It may be smooth enlargement or irregular enlargement. Regular enlargement. Tell me some causes. The commonest cause. Generalized hepatomegaly with jaundice, and it is a regular enlargement or smooth enlargement.
Hepatitis, viral hepatitis.
Very good. Hepatitis. Next.
Cirrhosis of liver.
Cirrhosis. Cirrhosis of the liver. In the early stages it is palpable, but usually it is contracted. That is not palpable. Okay, anything else? Surgical condition. Yes. Secondaries.
Yes, sir. Yes.
Secondaries will produce usually irregularity or nodularity, isn't it?
Yes, yes.
I said smooth enlargement of the liver. Tell me, hepatocellular carcinoma usually manifests as solitary enlargement of the liver as a mass. Only in rare cases presents as a diffuse infiltrative type where the liver is grossly enlarged, but it is not smooth, it is uneven or irregular. Any other surgical condition? Hepatitis is actually a medical condition. Cholangitis. So viral hepatitis, cholangitis, pylophlebitis, they produce regular enlargement. The next is the obstructive jaundice. Obstructive jaundice produces diffuse hepatomegaly, which is smooth in contour. Then the irregular enlargement with jaundice. Diffuse hepatomegaly, surface is irregular. jaundice is present? What do you suspect?
Secondary and cirrhosis.
Second is liver and cirrhosis. Very good. Then generalized enlargement, but there is no jaundice. Regular or smooth enlargement. Tell me the conditions.
Congestive hepatomegaly.
Congestive hepatomegaly. Can you tell me the cause for that?
Right side heart failure.
Cardiac.
Very good. Right side or congestive cardiac failure. This is one of the most important cause for the regular smooth enlargement without jaundice. Next, tell me other causes.
Fatty liver.
Is any infiltration of the liver, fatty liver, amyloidosis, leukemia infiltration, Bolisetty syndrome, then cirrhosis of the liver. In the early stages, there will be enlargement of the liver, but there is no jaundice. When jaundice is there, means that indicates that there is hepatocellular insufficiency in cirrhosis. So that is considered as a late stage. Tell me the causes for generalized hepatomegaly, which is irregular and there is no jaundice. Pardon? Please repeat.
Polycystic disease of liver.
Polycystic disease of liver, very rare. Common thing. Generalized diffuse hepatomegaly, which is irregular. No jaundice. Yes. Whenever an irregular liver is palpable, you must always consider secondaries in the liver. Rare condition is gamma, and of course, as you said, polycystic disease of the liver. Localized enlargement of the liver, with or without jaundice. What are the conditions you think of?
Middle slope.
Renal slope. Next.
Liver abscess, hydrated cyst.
MEB caps of the liver, hydrated cyst. Next.
Primary hepatocellular carcinoma.
Hepatocellular carcinoma. Very good.
Solitary secondary from colon cancer.
Very good. Excellent. So these are the conditions for the localized enlargement. For example, if there is a localized enlargement of the liver in the upper segments, then it manifests as a generalized enlargement because the liver is simply displaced down by a mass in the upper portion of the liver. So then it presents like a diffuse enlargement of the liver. Massive enlargement. When our liver is enlarged below the level of the umbilicus, you must consider these things. If it is irregular, if it is regular, venous congestion, Bolisetty syndrome, infiltration by lymphomas, that is Hodgkin's disease, fatty infiltration, amyloidosis, massive irregular enlargement, secondaries, hepatocellular carcinoma, rarely. A benign tumor like cholangiohepatoadenoma in patients with biliary cirrhosis and in children. Polycystosis of liver in children or young adults. So these are the causes for hepatomegaly. Liver is palpable and at the same time it is pulsatile. What is the cause? Pulsatile. Wonderful. You are right. An enlarged liver with treatment suddenly decreases in a day or 2 or 3 days, then what do you suspect? Sudden decrease in size of the liver can be due to acute massive hepatic necrosis. For example, a fatty infiltration or alcoholic hepatitis or cirrhosis of the liver. Suddenly the liver is not palpable. That means the patient is going to hepatic necrosis. Then in treated case of congestive cardiac failure and fatty infiltration, the size of the hepatomegaly suddenly decreases in 3 to 4 days time. Okay, now please tell me about the clinical features of a renal swelling.
Sir, it is a bilateral swelling, does not move with respiration, and can present with flank fullness.
Is it a swelling which doesn't move on respiration, renal swelling?
Moves very little with respiration.
Yes, you are right. Renal swellings move with respiration, but to a limited extent. So their movement is restricted. So they move, but little. When compared to liver swelling or gastric swelling, their movement is little. How do you test? What is the literal meaning of bilaterality? What is the literal meaning of bilaterality? Is tossing. For example, if you take a coin and you just toss it, it moves up and down. Similarly, what you do is you keep your hand under the flank and keep your right hand over the front of the abdomen. Then you just toss the swelling with your left hand like this. The swelling goes anti-reverse and touches your right hand and again falls down. So this just speaks about the anterior-posterior mobility of the swelling, that's all. A liver swelling, because it is a very huge mass of liver is there and from that a small mass is projecting out, it won't move just like that. So to differentiate between renal and liver swelling, so we do this test called bilaterality or tossing. So clinical renal swelling is a lump in the loin which is bimanually palpable, bilateral, and upper border is not palpable. Moves with respiration, colonic band of resonance is present. Renal angle shows fullness, tenderness, and dullness. Renal angle means the angle between 12th rib and lateral bottom of erector spinae muscle. If there is no renal swelling, that means for a normal person, will this angle dull or resonant? Normally.
Resonant, sir. Resonant.
What is the cause for this resonance?
Sir, ascending and descending colon.
Ascending and descending colon. So you are testing the percussion note on the back of the abdomen. Ascending and descending colon, are they situated anterior to the kidney or posterior to the kidney?
Slightly lateral posterior.
Posterior? Is kidney posterior or colon posterior?
Anterior and lateral to the kidney.
Very good. The colon is anterior and lateral to the kidney, and that portion of the colon which is situated lateral to the kidney border. For example, you can see here, this is the kidney border and colon is still more laterally present. So this part of the colon is touching the posterior abdominal wall. So this part gives the resonance. When you percuss it from the back, that is from the renal angle. So this portion gives the resonant note. When kidney enlarges or expands laterally. So it expands laterally and this whole colon now will have the posterior relationship of the enlarged kidney. So the kidney intervenes between the abdominal wall and the colon. So you don't get the resonant note. That is why it is dull on percussion. In the previous days, the examiners used to ask this question quite frequently in the exams, in the clinicals. So whenever you feel a kidney swelling, you must check for these points. Is the swelling a renal swelling or not? Is it unilateral or bilateral renal enlargement? Is it a regular or irregular enlargement of the kidney? Is it a solid or a cystic swelling? If it is unilateral renal mass, if it is solid, what is your diagnosis?
Renal cell carcinoma.
Very good. In adults, it is renal cell carcinoma. In children, it is Wilms tumor. Sometimes polycystic kidney may be palpable on only one side. Though it is there on both sides, it may be palpable on only one side. The other side may be very small, so it may not be palpable. Unilateral cystic renal swelling.
Hydronephrosis.
Very good. Bilateral renal swellings. Solid with polycystic kidneys, cystic, bilateral hydronephrosis. Then a mass from the pylorus. You tell me the clinical features of a mass from the stomach.
So peristalsis will be present.
Peristalsis may be present, not will be present. Only when there is gastric outlet obstruction, then only there will be peristalsis. Okay, next.
Tympanic node.
Tympanic node may be present. Again, if the mass is there arising from the posterior wall of the stomach, it is resonant. If it is there from the anterior wall of the stomach, it is dull on percussion. Next. What about the intrinsic mobility in the peritoneal cavity?
Will not be there.
No, it is mobile if it doesn't infiltrate the surrounding organs, like pancreas or post-abdominal wall. Mobility present, upper border is palpable, dull or resonant depending upon the site of the mass. Dullness is not contagious with liver dullness, associated with visible gastric peristalsis from left to right if there is associated gastric outlet obstruction. Colonic mass, a mass from the transverse colon. What are the clinical features? Tell me. If it is a gastric mass, what is your differential diagnosis? To diagnose a mass from the stomach, what is your differential diagnosis or what is your diagnosis?
Sir, gist.
Cystanesis will be in colon mass, it will be on right to left, sir. In gastric mass, it is left to right, sir.
Okay. Now, my question is now, what are the causes of clinically palpable gastric masses?
Gist, sir.
You tell me the common thing, not the rare thing.
Adenocarcinoma of stomach.
Wonderful. Carcinoma of the stomach. That is the commonest thing. About 95 to 98% of malignant tumors of the stomach are due to adenocarcinoma. Only 3 to 5% are because of gist tumors. That is why gist tumors must be only the second to be told, not the first one. Okay. So whenever you feel a mass from the stomach means you must consider it to be carcinoma of the stomach. Okay. Colonic masses, tell me. Okay, the percentage will be from right to left. Okay then.
Sir, pyloric mass also intrinsic mobility will be present, sir.
Yes, pylorus also is mobile. Pylorus, is it has a complete interpetal? Sorry, is it having a peritoneal covering on all sides or not?
Yes. Yes.
So any structure which has peritoneal covering on all sides is mobile, unless there is infiltration to the surrounding structures. So pyloric mass also is mobile intrinsically. You can move it up and down as well as laterally.
Thank you, sir.
Okay. Colonic mass is associated with fecal fullness and gurgling. Visual pressure from right to left may be present. Movement with respiration absent or slowly moves, or slightly moves. Mobility present. The flexure and ascending colon is absent. Gallbladder swelling. Okay. What are the causes for colonic mass?
Adenocarcinoma.
Adenocarcinoma. Next. Any other thing more common than adenocarcinoma? Especially in our country.
Bilateral TB.
Huh?
Tuberculosis, sir.
Yeah, very good. Which type of tuberculosis?
Hyperplastic.
Hyperplastic tuberculosis. Very good. Gallbladder swelling. Upper body is palpable and spherical or globular. Presents like a localized liver mass and difficult to differentiate solid mass from liver mass usually. So these are the viscera that can cause the masses in the right hypochondrial region. So let us consider the masses arising from these structures in the clinical presentation scenario. Commonly seen, uncommonly seen, rarely seen. Commonly seen swellings being liver, hydatid, amoebic abscess, hepatoma, stomach carcinoma, colon carcinoma, kidney hydronephrosis carcinoma, Wilms tumor. Gallbladder, bile duct, pancreas swellings, they are not commonly seen. Then uncommonly seen pyogenic abscess, tuberculosis of the colon, pyonephrosis of the kidney, mucosal of the gallbladder, pseudopancreatic cyst in the head of the pancreas. Rarely seen swellings being tuberculosis of the liver, gamma, renal lobe, actinomycosis of the liver. Stomach gist tumors, old name was leiomyoma and leiomyosarcoma. Kidney, tuberculosis of the kidney. Then gallbladder, carcinoma of the gallbladder for the bile ducts, colorectal cyst. Then pancreas, true cysts of the pancreas. So these are the causes of masses in the right hypochondrial region.
Dear friends, thank you for seeing this presentation. For live online surgery classes, please visit yogirambi.com, or you can contact by this phone number 8466806242 India, or you can mail to yogirambi@gmail.com. Thank you once again for your visit to this video. Thank you.